Thank you, Felix, for an excellent presentation of the case, and Dr. Agaba, thank you for your very kind introduction. I just wanted to say a couple of words about our relationship with Uganda. First of all, I just wanted to thank all of you. Can't hear? How about now? Sorry. I just wanted to thank all of you for inviting us and being so hospitable to us. I was telling my friends and my colleagues and the residents that we brought here that I've been to many, many countries in my life, and I can't think of a single country that's so kind and hospitable as Uganda. So I wanted to thank you for being like that. Please don't change. And I pray and I hope that our collaboration, our friendship, and our brotherhood and our sisterhood stay and remain forever, and that's my only wish. So thank you, and I learned a lot from you. I learned a lot from Dr. Agaba. We share our knowledge, right? And we become very good friends. In fact, if I named all the friendships that I have here, I don't think I'd have a paper list to fill that paper, because it's endless, and I just wanted to relay that to you. So thank you very much, and thank you for inviting me to these rounds. And it's nice to see a full house, and it makes me a little nervous, but thank you so much. I'm just going to get rid of the Wi-Fi thing here. Great. So I'm going to go through this. I know the case has been presented, and I'll go through some of the objectives that are important for hypopituitarism. But in order to understand hypopituitarism, you have to understand the sella turcica, which is where the pituitary gland sits. Thank you. Some of the clinical manifestations, the diagnosis, the differential diagnosis. We'll talk a little bit about the radiology and the hormonal evaluation and the treatment. So as everyone knows, the most important organ in the body, we always think it's maybe the heart. But it is probably the pituitary gland, because without a pituitary gland, the heart wouldn't function, because that little pea-sized gland has an effect on every single organ system in the body. And I hope Dr. Agaba agrees with that it's a very important organ. It's tiny, it grows a little bit in pregnancy, but it's actually a very tiny organ. And there is a stalk, as Dr. Agaba mentioned, that connects the hypothalamus to the pituitary gland, both the anterior and the posterior pituitary. So a little bit of functional anatomy. So as you can see, you have the anterior pituitary that is connected to the hypothalamus with the stalk. And surrounding this are the ventricles. And if you want to see where it exactly is, you just take your finger and just cross like this, and that's where the pituitary gland is. It's a little pea-sized gland. So people always ask me, why did I do endocrinology? Simple answer. So it took me 6 years to learn 3 things. Either it's too much, too little, or it's not sensing. That's endocrinology in 10 seconds. It's all about feedback. From the hypothalamus to the pituitary to the end organs, which you can think about what they are. So how do patients with pituitary disease present? It depends who's seeing them. Often it's the family doctor that might see them. The endocrinologist may see them at a later stage. The neurosurgeons often see them, but I can name many, many specialists. Respirology, cardiology, neurology, ophthalmology. It depends on what the presentation is. Is it a structural symptom or is it a hormonal symptom? And we'll go through some of the symptoms and signs to show you, I'll prove to you that it can be seen by many, many people. And the problem is, it's often missed because the training in endocrinology, even in Canada, is not as strong in their undergrad and the postgrad, because we're so focused on diabetes alone, or cardiovascular disease, or heart failure, but people often think about less common things which are very important, such as pituitary disease. So neurological symptoms are not uncommon, especially if the tumor is big or the lesion's big, especially with headaches and visual changes, in particular visual field deficits. Sometimes we might miss them on confrontation, on physical examination, but as Felix showed you, if you do them formally, that's when you might pick them up. I think there's about, how many people here? There's about 100 and something people here right now. It's a pretty full house. Don't get an MRI unless you need one, because 10% of you here have a pituitary lesion. I can guarantee you, I can bet that about 10% here have a pituitary lesion. Does it probably mean anything? Probably not, but it's going to cause you a lot of anxiety. So unless you have a reason, please don't go for an MRI of the sella turcica, or even an MRI of the head or the brain. And they may also present with functions that are overactive with the pituitary or underactive symptoms, and I'll go into that in just a little bit of detail. So a little mnemonic for the house staff. So I examine in Ottawa at the Royal College along with my colleague here, Dr. O'Keefe, and we try to make things practical when we teach. So there's a nice mnemonic to remember all the hormones in the pituitary gland, which are in the anterior pituitary. It's a nice mnemonic called go, look for the adenoma, please. So G for growth hormone, L for luteinizing hormone, F for follicle stimulating hormone, T for thyrotroph, or thyroid stimulating hormone, A for ACTH, and P for prolactin. Now that's just the anterior pituitary. And generally speaking, when you have a lesion, that's the order where you lose the hormones. So the last thing to be lost is actually prolactin. But the first thing often to be lost is the growth hormone axis. And how do they present? I'm not going to talk deeply about all these deficiencies because you can think about what they do and you can figure out often the clinical symptoms and signs. Growth hormone deficiency, more common in children, but not uncommon in adults. The problem is even in the Western world, it's very expensive. The cost of growth hormone therapy for a year is over $15,000. I have lots of patients on growth hormone, but these are patients who are covered by private payers. I think we have many more other problems in the developing world than growth hormone deficiencies. We have to prioritize. Hypogonadism, testosterone or estrogen deficiency is another problem. Hypothyroidism is very common. And adrenal insufficiency. So the reason I put adrenal insufficiency and diabetes insipidus in red is because these are life important hormones. If you don't have corticotropes, if you don't have ACTH, you will not survive. If you have uncontrolled diabetes insipidus and you go to a desert or a hot area where you don't have access to water, you will die. If you don't have testosterone, you can argue that you probably won't die, although some men may beg to differ, right? But you probably don't need testosterone to live a reasonable life. It depends on the patient, obviously. But these are the important hormones. So this is a nice table. I'm not going to go through this table, but if you look at this table, the point I'm trying to make here is pituitary hormones can have effect on every single organ, which is the heart, the lungs, the muscles, fertility, and think about every single organ and you'll have an effect. And I'd be happy to share this presentation with you if you want to go into more detail. But I think Felix did a very nice job of demonstrating hypopituitarism affecting almost every single organ system. The only thing with that case that bothers me when I was looking through the case is that it is very rare. In fact, I have still yet to see a case, and I do a lot of pituitary disease. I see about 3 or 4 new pituitaries every week, functioning and non-functioning. For someone to get diabetes insipidus with a macroadenoma, it's rare. When you see diabetes insipidus with a Sellar mass, you have to think of other things, like a craniopharyngioma, a germ cell tumor, a metastatic lesion, often a lymphoma, breast or lung or thyroid. But it's very rare to get diabetes insipidus with macroadenoma. So that's the only thing that bothers me from the pathological level. Unless this patient was just drinking a lot because he liked to drink because it was hot, and it's not really, it's more polydipsia rather than diabetes insipidus, like a psychogenic or a thirst center issue. I don't think we have investigations to prove either, but I don't think if it is a macroadenoma that this is a macroadenoma. It must be something else if it's true diabetes insipidus. Very important teaching point. Just like the teaching point that Dr. Agama made, that if you're thinking of central hypothyroidism, TSH is a useless test. It's the free T4. In fact, in central hypothyroidism, the TSH actually can be a little bit elevated because it's a bio-inactive TSH that might be just a little bit high, where the free T4 is in the boots. Very important teaching point. I know most cases of hypothyroidism are primary, where the TSH is very, very high, but if someone's got a constellation of hypopituitary symptoms, then you've got to do the full panel looking for pituitary disease, and it's the free T4 that you need to do for central hypothyroidism. So if someone still has symptoms of hypothyroidism, the TSH is normal, and your suspicion is high, please do a T4. You're going to miss the diagnosis, and it's easily treatable. Very easily treatable. We often think about the left atrium, we often think about the ventricle in cardiology. We often forget the atrium. We do the same thing in endocrinology. We often think about the anterior pituitary, but we forget the posterior pituitary. The hypothalamic derived posterior pituitary, which produces which hormone? Antidiuretic hormone, or vasopressin, right? But thank good we have it, right? Because if we didn't have ADH, we would not survive. We'd be just urinating all the time and become dehydrated if you walked around Bulago because it's so hot. So central diabetes insipidus, I'm not going to talk about nephrogenic, it's a different disease. But by the definition of polyuria is 50 mils per kilogram per day. So it's weight-based definition. And often patients with central diabetes insipidus have significant polydipsia, which is often abrupt, and they have a craving for cold, icy fluids, unlike nephrogenic, where it's more gradual, and they don't mind warm fluids also. So when someone has abrupt polydipsia, a thirst quench for cold, icy fluids, think of diabetes insipidus central. And how do these patients, biochemically, how do they present? They have a high serum osmolality and a urine osmolality that's low because they're dilute. Makes sense, right? They're peeing out free water, so your urine will be dilute. And hypernatremia is very uncommon. Why is hypernatremia uncommon in diabetes insipidus? You would think it should be common. Why? Because they have hands that can reach for water. If you take an elderly patient with a stroke or paralysis, if they have DI or diabetes insipidus, they will become hypernatremic. So as long as you have access and your third center is intact, your adipsic center is intact, you're not going to get hypernatremia. If you get hypernatremia, you're in big trouble. So that's a little bit about hypopituitarism in the sense of presenting symptoms and signs. What about hyperpituitarism? When you see a Sellar mass, you must do a few tests because it's going to change your therapeutic options, whether it's surgical or non-surgical. So prolactin is a must. If the prolactin is less than 100 in these units, it's probably not a prolactin, as Dr. Agaba said. But if it's 1,000 or 2,000, this is a medical tumor. This is a tumor that's going to shrink before your eyes, and the visual fields will get better within a month, and your diplopia will go within a month with a little bit of dopamine agonist therapy. I do it all the time. I run up to the ward on 7 West. The inexperienced neurosurgeons want to operate, and I go, please give me a few days. And they go, sure, because we do a lot of this. We put them on cabergoline or bromocriptine or quinagalide, and these tumors shrink. Medina, before you came on, this was happening all the time. But now we have this collaboration, right? They don't operate until they see us. They ask our opinion. These prolactins go down from 1,000 to 2,000 to like 50s within a few months. Okay, great. So that's prolactinoma. And I'll talk a little bit more about that later, okay? So the second most important functioning tumor is acromegaly, growth hormone excess, and I'll show you some pictures. Again, to talk about acromegaly in full would take a whole session, so I'm just going to mention growth hormone excess. Does anyone know Andre the Giant? He's a wrestler. So if you imagine Andre the Giant, he had gigantism, which is prepubertal growth hormone excess. Cushing syndrome. You see a lot of Cushing syndrome in Uganda, right? But it's often not endogenous Cushing's in Uganda. It's exogenous because people can buy prednisone or glucocorticoids from the pharmacies without a prescription. So it's just the patients that they're doing it to themselves, or they have rheumatoid arthritis or some other connective tissue disease. They're taking it and they're presenting with Cushing syndrome, but it's exogenous. A little bit different. And the reason I put hyperthyroidism in a smaller font, did you notice that? There's a reason, because this is the rarest functioning pituitary tumor. Thyrotoxicosis, central hyperthyroidism is very, very rare. So acromegaly. Who's seen a case of acromegaly in clinical practice? It's rare, right? We have a lot. It's a disease often in the 40s and the 50s where everything gets big, but it also has metabolic sequelae. Diabetes, hypertension, cardiovascular disease, sleep apnea. It's associated with colonic polyps, perhaps colonic cancer. There's a lot of associations, respiratory disease and so on. It's probably one of the worst diseases to have. You know, I wouldn't want my worst enemy to get acromegaly. So back again to some clinical structural manifestations. So I've already talked about the visual fields that can be affected, and that's because of impingement on the optic chiasm, which sits superior to the pituitary gland. Sometimes you can get ocular dysfunction with cranial nerves 3, 4, and 6 because of the cavernous sinus, which are lateral to the sella. And acuity can be affected also if there's a very large tumor. Headaches are not uncommon, and very, very rarely you can get CSF leak because of CSF rhinorrhea. Again, it's very uncommon preoperatively, but when the surgeons operate, CSF leak, even in our institutions, they're actually not uncommon, it can happen. So what are the causes of hypopituitarism? I'm going to go through that. So the most common cause, as Felix mentioned, probably in his case, is a pituitary adenoma, a macroadenoma. Most common. But there are other things that can give you a lesion in the sella turcica. Pituitary hyperplasia, and I'm going to talk about that in just a second. Other benign pituitary tumors or secondary metastatic lesions, in particular lymphoma, breast cancer that is metastasized, thyroid, and lung cancer, especially squamous cell and non-small cell. Certain cysts, abscesses, and I put that in red because in Uganda, this is probably more relevant, right? Tuberculosis is not uncommon to the sella turcica. HIV manifestations are not, abscesses are not uncommon. Nocardia, all these things can manifest in the sella turcica. And there's some vascular aneurysms that can happen that are rare. Lymphocytic hypophysitis, very uncommon. We're seeing a lot more in the Western world because we're using these drugs, the immune checkpoint inhibitors that we're using for cancer, the MABs, the monoclonal antibodies. They're actually activating the immune system. One day they will come to Uganda and you're going to see these things at that stage too. But fortunately right now it's not a big issue in many other parts of the world. And infiltrative conditions, hemochromatosis, sarcoidosis, which you probably see here also, and histiocytosis X, or Langerhans cell histiocytosis. So the most common cause, again, just want to be redundant a little bit so you get the message across, is a pituitary macroadenoma. And the definition of a macro is a 1 centimeter cutoff. And these are the ones that are at risk for hypopituitarism, and they have the structural effects, the headaches, the visual field deficits, the extraocular movement dysfunction. Micros are less than 1 centimeter. These are small, but they can be very, very functional. They can cause acromegaly and Cushing's, but they won't cause hypopit due to structural effects because they're so small. But they can cause hypopit because of functional effects. If you have very high cortisol levels, you can have a 2 millimeter Cushing syndrome, but it can cause you to become infertile and hypogonadal because that cortisol is suppressing the gonadotropins. That cortisol can suppress the TSH. So where do they come from? They come from the pituitary cell of origin, okay? Most common status of pituitary adenomas is non-functioning. We call them null cell tumors. The second most common cause of a pituitary adenoma is a prolactinoma, and these are medical tumors, as I mentioned earlier on. And less common again, acromegaly, Cushing's, and thyrotoxicosis. Now, Felix, you mentioned flank pain. You said don't worry about it. I'm actually worried about that. Why would someone be worried about flank pain when you're working at pituitary disease? Anyone have any thoughts there? So when someone has flank pain, what do you think about? Acute flank pain. Sorry? Okay, adrenal, it's very rare to get adrenal hemorrhage. Flank pain, you're writhing in pain, you can't sit still. What condition would that be?
Stones.
Kidney stones. So what's the most common cause of kidney stones? Calcium. So what's the most common cause of hypercalciuria? Hypercalcemia. What's the most common cause of hypercalcemia? Primary hyperparathyroidism. Okay, what's the least common cause of hyperparathyroidism? Multiple endocrine neoplasia type 1. The 3 Ps, right? Parathyroid, pancreas, neuroendocrine tumors, and pituitary. So that was a very relevant question you asked. I thought it was, wow, this guy's really good. It's very important, okay? I'm glad you put that up there. So I do ask about flank pain and kidney stones, okay? Very important. So I just wanted to mention pituitary hyperplasia. Even though the TSH can be normal in hypothyroidism, you must check a TSH before you send them to a surgeon. Because if the TSH is very, very high, it can be a pseudo lesion. It could be pituitary hyperplasia. And how do you treat that? You give them thyroxine, and that lesion will shrink because it's all about negative feedback. Okay, that's very, very important. So TSH is very important. Quickly, what are other causes of sellar masses and hypopituitarism? Craniopharyngiomas. They look different. They present differently. They present with DI and headaches. Young people and not as young people. Okay, there's a bimodal distribution of craniopharyngiomas. And DI is diabetes insipidus is common, unlike macroadenomas preoperatively. Then there are meningiomas who present with structural effects. They're very common also. We see a lot of meningiomas, sellar meningiomas. Germ cell tumors, not too common. Think about it in young people. They present with DI and hypopit, and a lesion in the sella and a lesion in the pineal gland. We call them a double lesion, and we see these. We look for these. I like to look at all my films myself. Lymphomas, again, not common. Chordomas, less common. Sarcomas, and all the other lesions, not as common, okay? There's the giant ones. You know how there's also the geriatric giants? There's the pituitary giants. Adenomas, astrocytomas. We already talked about adenomas, craniopharyngiomas, meningiomas. Those are the big ones, okay? Big ones. And hyperplasia. Okay, I'm gonna zip. I've already talked about some of these, so I'm not gonna. I just wanted to spend a second on infiltrative diseases, okay? Again, very rare. Histiocytosis X is very, very rare. But think about it if someone has lung manifestations also, okay? Because you can get it in the lungs and the pituitary and the bone marrow. So look for patterns. That's why we do a CBC. Because if they have cytopenias, a sellar mass, and skin manifestations and lung manifestations, think about histiocytosis X or Langerhans cells syndrome. And sarcoidosis, not uncommon, right? It's very common actually, sarcoidosis. Most common presentation is bilateral lymphadenopathy, as we know. So what's the best imaging study for a sellar mass? CT is not the best test, but it's better than nothing. It's the MRI with gadolinium, which is a contrast. And you want to look at the MRI very carefully with a good radiologist. Now I look at them myself, but I'm not a radiologist. If I'm concerned, I'll look at the report, and if I'm concerned, I'll take it back to my neuroradiologist, not just an ordinary radiologist, and go through all these things, because that'll help me with the differential diagnosis. You still got to go back to clinical and the biochemical, but you still need to relate the radiological to the patient in front of you. Otherwise, you're going to miss the boat. Okay? Everything is not an adenoma. It could be other things too. You want to look at the size, the density. That's what the gadolinium helps, right? Are there any cystic aspects to it? Is there calcification? I go through all these checklists in my mind. Then a differential diagnosis pops out, okay? How big is it? How does it extend? Can you see the posterior pituitary bright spot suggestive of diabetes insipidus if it's absent? And is it in contiguity with the pituitary? If it's not, think about other things also. And the stalk size and the deviation. So on the left, you'll see see how small the gland is? You can see it is the arrow slants there, right? Very, very small. I'm just showing you some functional anatomy here. Thank you. Oh, thanks. So that's the normal pituitary gland, right? That's a sagittal view. Remember we learned that in medical school, sagittal. What view is this? This is the most important view with pituitary disease. The coronal view. The coronal view. That's the view. I'm not a radiologist, right? I know functional anatomy, but I don't know. I know functional anatomy. So this is the coronal view. So that's the anterior pituitary gland. What's this? This is the which artery is this? This is the carotid artery. This is the cavernous sinus, right? Cavernous. This is the ICA, the internal carotid artery. This is the pituitary, and this is the sphenoid sinus, right? This is the sella here, and what's this? That's the stalk, right? And that's the optic chiasm. So a little bit of functional anatomy, and if you can understand that, you can understand pituitary disease. Now this, you don't need an arrow, right? What's that? That's the sella turcica. That's a huge pituitary or sellar lesion. And this is almost certainly a macroadenoma, just by the features. Skip that. So what other evaluation do you need when you see a sellar mass or you're thinking about hypopituitarism? A CT scan can be helpful for the surgeon for planning, because most of the surgeries for pituitary are done via the nose, endoscopically, with an ENT doctor that goes in first, get to the nose, and the surgeon, and the neurosurgeon or the pituitary surgeon takes over. We may do a chest x-ray, depending on what the cause is, and here it might be worthwhile if you're thinking of tuberculosis or sarcoidosis, but formal visual fields are very important, and those visual fields were completely normal. I was a little surprised that those visual fields were totally normal. Yeah, big lesion like that, I would have expected some bitemporal lesion effects, but they look normal to me too, totally normal. In fact, probably as good as any one of ours visual fields. A lumbar puncture, again, I'm thinking if you're thinking HIV and tuberculosis as a cause, and a biopsy is not very commonly needed unless you're thinking of a germ cell, because germ cell tumors are not chemotherapy sensitive or surgically sensitive. These are radiosensitive tumors. I just had a patient a few years ago, I think, Medina, you've seen this patient, a young, nice man, Mr. PW. Young man, presented to me with hypopit. His MRI was booked for a year later. I saw him that day, I got him an MRI the same day because my suspicion was so high that he had hypopit. He had a double lesion, a pineal gland lesion and a sellar lesion, which when I looked at it, it looked like a germinoma. He got radiation therapy. Within 6 months, the lesions were gone. His gonadal status got a little bit better, but unfortunately he remained hypopit because it's just the effects, the long effects that he had it for. He couldn't reverse, but he felt better. His visual fields got better, and the tumor went away. He's under surveillance right now. So these are these normal or abnormal? Abnormal. These are abnormal. You know, these are pretty abnormal, right? So how would you describe these? These are beautiful visual fields, right? How would you describe these visual fields? Anyone want to take a crack? Okay, so the left eye and the right eye, they're labeled.
Yeah, bitemporal.
So bitemporal.
Yeah.
You want to be more specific? I agree.
So this would be described as bitemporal heminopia.
Okay, even more, is it complete heminopia?
Incomplete.
So it's superior. So it's bitemporal, superior quadranopia. Okay. Hemi means complete, left or right, but this is a superior quadranopia, right? Because you've got the superior quadrants only, and the inferior quadrants are spared. So this patient basically can't see above. Okay, patient probably can drive okay, but probably can't reach for things. Probably has sort of like can't see above, okay? And probably can walk okay because he or she can still walk around and not fall, but difficulty reaching for things. And probably shouldn't be skiing, right? It's not an issue here, but this patient will have a tough time going uphill and so on. Okay, hormonal evaluation. So I'm going to put the key things in red here. If someone has a lesion, you must do a prolactin, because if you don't do a prolactin, you might miss a medical tumor. And in fact, for prolactinomas, often the prolactin levels are very, very high. And again, to complete the workup, I understand resources in different areas and I respect that very highly. If you have the resources, you should probably do in a large lesion some aspect of the growth hormone axis, and the best test is IGF-1, insulin-like growth factor -1, because that'll tell you about acromegaly. There are certain cases which are very subtle. You might miss clinical acromegaly, but the IGF level may be a little bit high, and they carry some risk of the morbidities with acromegaly, the cardiovascular and the respiratory morbidity. Again, for the gonadal status, we've already talked about that. And you must do a free T4 for hypothyroidism and a TSH to rule out pituitary hyperplasia. And for Cushing's, you're going to do Cushing studies, urine-free cortisol, and we can get 11 p.m. salivary cortisol, which is probably the best test for Cushing's. Even in the Western world, it's not as easily available. I do it because I see a lot of pituitary disease, but most people don't do it because it's hard to get. And it's an endocrine test. It's not something that I would expect a general internist or a family doctor to order, because that's when they should be referred. And electrolytes if you're thinking of DI with hypernatremia. Hypofunctioning, very important, adrenal. If you don't replace adrenal hormones, you're not going to survive. So what's the best test? Do a random cortisol if you don't have time. But if you have time, do a morning cortisol. Remember, cortisol peaks in the morning and it starts going lower as the day goes on. And the reason for that is we need it in the morning so we can be hyped up. We can get the day going. And the reason why we want it low at night is so we can sleep. If your cortisol levels are at high, you're not going to sleep. It's going to keep you up. So simple numbers to remember. A cortisol in the morning, if it's above 400 nanomole per liter, you probably don't have the disease if you're stable. If you do a cortisone stim, ACTH stim, which we can do with 250 microgram, we were looking for a number more than 500 nanomole per liter. And as you saw in your case, it was 37, which is unequivocally, undebatably low. I wouldn't even go on to do ACTH stim unless I had issues with the assay or there was a clinical discordance. But that patient had beautiful clinical signs and symptoms and unequivocally low cortisol level. You clinched the diagnosis of central adrenal insufficiency with a normal corticotroph level, ACTH, adrenocorticotroph level, hormone. Free T4 for thyroid, I've already talked about that, not TSH. Other hormones, not as important. I'm going to zip through them because these aren't as important in terms of priorities. Test for hypogonadism, both the women and men. Now, if a woman has normal menstrual cycles, you don't need to do an estrogen. You got the bio estrogen is the normal menstrual cycles. That's telling you what the gonadal status is. Men it's a little more challenging. Okay, growth hormone deficiency, probably not that relevant. Do you want me to talk a lot about growth? Do you want me to mention growth hormone deficiency? Okay, growth hormone deficiency, as I mentioned, in adults is common but often not treated because it's very expensive. And there's no good clinical outcome studies to show that it makes a difference from the clinical outcome point of view. But in order to prove it, you need to do some dynamic testing to stimulate growth hormone. The gold standard test is an insulin tolerance test, where you give someone insulin, they drop their sugar, and the normal response in human beings is the growth hormone rises very, very high. You can also do a growth hormone releasing hormone stimulation, glucagon stimulation, arginine stimulation. Again, we do it not as often because everyone can't get treated. Even in Canada, it's not affordable for many, many people. $15,000 a year. But if your IGF-1 level is low and you have multiple hormonal deficiencies, the pretest probability of having growth hormone deficiency is very high. You don't need to do dynamic testing. So surgery. So I've talked about some of the dynamic testing, some of the static testing. So who should go for surgery? And this was a question that Dr. Agaba wanted me to address because that's important. If someone has unremitting headaches and you ruled out other causes of headaches, like headaches due to migraine, headaches due to another neoplastic lesion, headaches due to cluster headaches or tension headaches, you've done a very good history, and you think this is all due to that lesion in the sella, it may be an indication. That's when you get the pituitary surgeon involved. If someone has significant clinical growth, you're repeating their MRIs every 6 months, and you're noticing growth, it's probably good to intervene because if you repeated it the next time, at that time it may be impinging the optic chiasm, and the patient might end up going blind. So growth is very, very important. I'm going to leave out hypopituitarism for a second because that's this case here. I want to talk about that in a bit. If someone has visual field abnormalities, definitely an indication. You can regain their visual field. That's very important. And if they're functioning, acromegaly, Cushing syndrome, definitely intervene with a good pituitary surgeon, unless it's a prolactinoma. Then we're going to use dopamine agonist therapy, either cabergoline, bromocriptine, or quinabolide. I've already talked about the optic chiasm. If someone has pituitary apoplexy, which is bleeding into the sella, into the pituitary gland, it's a surgical endocrine emergency because that can bleed even more and cause optic chiasm issues and visual field deficits and blindness. If it's near the optic chiasm, and if they're planning to conceive, you might operate earlier than later because Remember, in pregnancy, the pituitary grows. So if you have a predisposing pituitary tumor that's already there, and if you become pregnant, you might get impending visual field loss. So you might want to operate sooner than later, okay? Before they're pregnant. So this is where conception counseling comes into mind. Let's go back to hypopituitarism. Should everyone with hypopituitarism get surgery? Controversial. And the reason I say controversial is if they don't have any other indications, about 50% of them gain back their their hormone deficiencies, but the other 50% don't. It's like a flip of the coin, or the flip of the coin. 50% one way, 50% the other. So it depends on resources. It's a discussion with the patient, and I really like the way you did the patient's perception. That's something that I've learned being in Uganda. We don't do a very good job of that in Canada. So I really appreciate that. So it's 50-50 with hypopituitarism. You got to talk to the patient. And again, resources is a big issue. If you don't have a surgeon, it's probably better. If you don't have a good surgeon, it's probably better that you don't operate, because the risk of having a bad surgeon, or I shouldn't say bad, or an inexperienced pituitary surgeon, the risk outweighs the benefit. Just follow them along. So, a little bit about non-surgical therapy in terms of now we're getting to hypopituitarism. I'm going to go from the most important hormones to the least important hormones in terms of life-sustaining therapy. So, chronic, central, or secondary adrenal insufficiency. The drug of choice, if available, is hydrocortisone. It's the most physiological, as we know so far. It's not ideal, because now we're looking into delayed release preparations, which are still in the research area. But in 2019, the best therapy we have for adrenal replacement therapy is hydrocortisone. Anywhere from 15, some people only need 10 milligram a day. You got to adjust based on the patient. You can base it on once a day dosing or TID dosing. This is where you monitor the patient and see how they feel the best. Less than optimal, but still not too bad, is prednisone and cortisone acetate. Here you have prednisolone, right? Same thing. Probably the drug you should probably use the least, if possible, if you can avoid, is dexamethasone. Dexamethasone is very long-acting and the most likely one to make you Cushingoid even at low doses. So dexamethasone is a surgical drug acutely for edema, vasogenic edema, and it's an oncological drug for chemotherapy. But for endocrine replacement therapy, dexamethasone probably should be minimized if possible, unless there's no other choice. Now, what's the cheapest glucocorticoid in Uganda? Is it prednisolone? And Dexa, yeah. So use prednisolone rather than Dexa. Good. So try not to use dexamethasone if possible, okay? Okay. Other treatments for adrenal insufficiency? Remember, the lowest dose possible. What do I start them on? I look at the patient, the gender. I start them on 15 milligram to 20 milligram a day. Then I'll bring them back again in a few months. And if they're feeling amazing, I might actually drop the dose. And I'll warn them what can happen if the dose is too low. Take the largest dose in the morning, because in the morning we need that kick so we can stay awake, right? And later on, we don't need that kick. You need to counsel them about sick day management, what to do if they get a fever, doubling up on the dose, getting them some kind of alert, either a card that you might have that identifies that they might have this disease. And we can also have kits for emergencies, such as a dexamethasone kit or a hydrocortisone kit, where the patient can take it with them. If they don't have access to a doctor right away, they can inject them and get to a hospital right away. Now, patients with central adrenal insufficiency, unlike primary or Addison's, don't need fludrocortisone or mineralocorticoid, because the renin-angiotensin-aldosterone system is intact. They won't have low high potassiums, right? Make sense? Remember, the adrenals are okay here. It's the pituitary which is the issue. The zona glomerulosa, which is the outer layer, is working okay. It's the zona fasciculata, the middle layer, which is the issue, which is not being triggered because there's ACTH deficiency. So the zona glomerulosa is okay, but the zona fasciculata is the impaired organ because of the lack of ACTH. You don't need ACTH for zona glomerulosa function. Okay, and it's another important point here is we actually published on this a few years ago, is certain anti-epileptic drugs like phenobarbital and then phenobarb and rifampin for TB can increase the metabolism of cortisol, so you may need a higher dose. Keep that in mind in your tuberculosis patients, okay? If they have adrenal insufficiency and you start them on rifampin, you're going to make them adrenally insufficient. These are dose equivalencies. As you can see, the most potent one I've already talked about is dexamethasone, and the least potent is cortisone acetate. These are just conversions just for glucocorticoid activity, not mineralocorticoid activity. So how about central hypothyroidism? So most people need roughly 1.6 microgram per kilogram per day. But in the elderly patients and the cardiovascular patients, start slow because you might unmask arrhythmias and worsen myocardial ischemia. And you're aiming for not a TSH, right? What are you aiming for? A free T4 in the mid to upper limit of normal. Why mid to upper limit of normal? Because you've had 2 studies in the last 5 years showing that if you keep them in the lower limit of normal, they have higher cardiovascular disease. That's the reasoning to keep them in the mid to upper limit of normal. And dose adjust every 4 to 6 weeks time because the half-life of thyroxine is how many days? What's the half-life of thyroxine? Anyone? 7 days. It's a week. That's why you wait 4 to 5 half-lives. Remember pharmacokinetics, right? It takes 4 to 6 half-lives for steady state. And don't use don't use T3 desiccated thyroid extracts. And the reason why is every time you buy something that's not approved or on formulary or approved in your local country, you might be getting something different every time with every different tablet. So it's going to be, your levels are going to swing up and down, okay? That's very important. And avoid high doses because of osteoporosis and cardiovascular disease with some of these drugs. And if you got them on an anti-epileptic drug, check the levels in 6 weeks' time because not only does certain anti-epileptic drugs affect cortisol, it can also affect thyroxine. Okay, diabetes insipidus. Again, everyone with diabetes insipidus may not need therapy if it's partial and they're compensating. But someone who's waking up 15 times a night, and I have patients like that post-op, and they just pee out clear liquid, like water. There's not a tinge of yellow. So you'll notice that when I do rounds, I look at the Foley catheter, the urometer, and I look at the color, because that can tell me if the patient has DI. If the patient if it's yellow, it's not DI. You don't need any tests. You need your eyes. You need 2 eyes to see that like's water, it's DI. If it's yellow, it's not DI. Okay? So who needs therapy for diabetes insipidus? Someone who's really bothered and you've proven the diagnosis, but DI can often reverse post-operatively. Okay? So give them a challenge for a day to see if they can stop their therapy and what happens. If they're back to normal, they don't need the therapy. But that's a small population, okay? And it's better to err on the side of not treating initially because the risk of hyponatremia is much higher than the risk of hypernatremia. Remember, with hyponatremia, they can seize, they can become drowsy, and can get GI symptoms and die. Hyponatremia is much more worrisome to me. I'm not worried about hypernatremia because the brain will sense it and you'll start drinking more. Hyponatremia, if you get drowsy, you're going to be gorked out and you're going to get a seizure. And there are certain patients who are adipsic. They don't have a thirst center. And these are the challenging patients, the craniopharyngiomas, because they have hypothalamic dysfunction. They can't sense, so you got to monitor them very carefully and gently. Allow them to be a little bit more polyuric than going into hyponatremia. So what are the therapies we have available for central diabetes insipidus? We use desmopressin. What do you guys use here? Same thing, right? We have 4 preparations. I'm not going to talk about intravenous or subcu because that's more in hospital. Outpatient therapies, we have nasal, which is the most common one that's used. And we have melt, which is sublingual, which is easy for most patients. And oral we don't use very much. It's not very good. The bioavailability of oral is very unpredictable. So it's either nasal or the melt. Again, resource-based, you got to do the best you can, right? So if the oral is the only one available, you got to use oral. And we have to respect the country and the population with the resources. That's what we do. Now, others are some sort of third-line therapies. We use chlorpropamide for people who can't get access to anything because chlorpropamide causes SIDH, right? Chlorpropamide is an anti-hyperglycemic. We used to use it for diabetes. It's a sulfonylurea. It can cause SIDH. So we use that as side effect as an advantage. Carbamazepine also, clofibrin, we don't use as much. Hydrochlorothiazide is a pretty good drug if you have nothing else available. Okay? Because what hydrochlorothiazide does is it increases distal delivery of sodium to the distal convoluted tubule, just distal to the loop of Henle in the nephron, and it causes reabsorption of water and sodium, but more water, so you actually can treat DI. A little bit of renal physiology can really help you there, right? I'm not a nephrologist, but that is the mechanism of action of or any thiazide diuretic. Chlorothalonone is probably the best. That's the one I use the most, but you can use hydrochlorothiazide also. And indomethacin more for nephrogenic diabetes and symptoms. So male hypogonadism, again, it's not a priority therapy. It's if you can afford and there's no contraindications. The only thing that has been proven to really help with testosterone therapy is sexual function. libido and overall sexual function. The ones in black, it may help, but most randomized controlled trials that we have don't show much of an effect on energy levels. It's case by case. I might give them a trial, but it has been unequivocally proven if you have hypogonadism with poor libido and erectile dysfunction and sexual dysfunction, then you want to use testosterone in the absence of the above contraindications. In particular, hormone-dependent malignancies in men. Prostate, and men can get breast cancer. About 1% of all breast cancer occurs in men. And we have several formulations. IM, topical, oral, and nasal formulations. We used to have auxiliary in the West, but that got discontinued just about a year ago, Axeron. Female, again, think about the contraindications. Cardiovascular and breast and uterine cancer being the most common. Again, we have oral formulations and topical formulations. Again, when you put someone on a birth control pill or estrogen, you're going to basically also decrease the levels of anti-epileptics. This is the opposite. If someone is seizure-free, okay, and you put them on estrogen and they start getting seizures, it's probably the hormone therapy. So if you see anti-epileptics, you've got to be very careful in monitoring levels and making sure you're not going to unmask previous seizures, okay? Very important Royal College question. I had that question on my Royal College exams. And fortunately, because I did endocrine training, or I was going into endocrine, I remember that, and fortunately it was helpful. Growth hormone deficiency, I've already talked about. Okay, so we've talked about the Sellar mass, we've talked about hypopituitarism, we talked about clinical manifestations, biochemical investigation, imaging, visual fields, and we talked about some of the therapies for chronic pan-hypopituitarism. Now let's talk a little bit about some nuances in terms of interactions between HRT, which is hormone replacement therapy in pituitary disease. So let's start off with glucocorticoids. So glucocorticoids, when you start someone with growth hormone, make sure you test the full axis, because if you don't, you might cause adrenal insufficiency. Because what growth hormone does is there's an enzyme called 18-hydroxydehydrogenase, which converts cortisol to cortisone. And what will happen is this will shunt towards producing more cortisone, which is weak. So you may worsen adrenal insufficiency. So check the axis again. Very important. Thyroid hormone, same thing again. Rule out adrenal insufficiency before starting thyroxine. Because what happens if someone has adrenal insufficiency and hypothyroidism, and you treat the hypothyroidism before treating the adrenal insufficiency? What can happen? It's already up there. You may worsen adrenal insufficiency, or you may unmask adrenal insufficiency. Two mechanisms. And if you know these, you know a lot of physiology. What are the two mechanisms? And Medina, I think we've talked about this, right? But I'm not going to ask you because we'll give everyone else a chance here. So then I'll ask you after, if no one else is willing to. I might ask Dr. Chriselbrink to answer that question. I'm not going to ask her now. This is a very important teaching point. So anyone know the reasoning behind if you treat someone with thyroxine before adrenal hormone therapy, why you can worsen adrenal insufficiency or unmask it? This is a Royal College question. So I'll give you some hints. Okay, so what does thyroid hormone do broadly? Sorry? Metabolism. Look, you guys are all smart. I'm going to lead you to the question, to the answer. So it's a metabolic hormone, right? So if you give someone thyroxine, is it going to cause increased metabolism or decreased metabolism?
Increased metabolism.
And what will it cause increased metabolism of? What drug or what hormone in the body? Which hormone am I worried about? Cortisol. It'll increase the metabolism of cortisol, so you'll become adrenally insufficient. So you've answered that question. That's the first mechanism. What's the second mechanism of treating someone with thyroxine before cortisone replacement causing adrenal insufficiency? So again, this is pharmacokinetics, right? All about pharmacokinetics. So where is cortisol bound? What is it bound to? It's bound to some kind of protein, right? A lot of hormones have protein binding, right? You know, there's dissociation, right? The Henderson, remember we have the dissociation curves, right? In the Ki-50s and so on. So there is a Ki-50 or dissociation between many hormones and proteins. So cortisol is bound to cortisol binding globulin, CBG. If you put someone on thyroxine, your CBG levels will go high. So what will happen to your total cortisol? It will go high. But what will happen to your free cortisol? It'll go low. Make sense? You'll never forget this again, right? Okay. Estrogen can also do the same thing. You can increase total cortisol. So remember that more in testing. And this is another important teaching point that bothered me in this case also. If someone has Diabetes insipidus. Adrenal insufficiency may mask diabetes insipidus, but if you treat their adrenal insufficiency, you might present worsening DI. So this patient actually didn't get worse, right, when you treated them. So that makes me think even less likely that your patient did not have diabetes insipidus. It was probably something else, probably just thirsty and hot and stuff, okay? That's a very important teaching point. Okay, HRT, so the next hormone is estrogen. So thyroid hormone, if there's changes in estrogen therapy, what does estrogen do to thyroxine levels? So what does thyroxine bind to? Again, pharmacokinetics, right? Thyroxine binds to thyroid binding globulin, TBG, right? If you give someone estrogen, you're going to increase TBG levels and lower the levels of free thyroxine. So you might worsen their hypothyroidism. So when you put someone on some kind of estrogen, check their free T4 if it's central, or check their TSH if it's primary, to see if you have to dose 6 weeks. Very important. At the onset of pregnancy, lots of estrogen, you do the same thing. That's why at the onset of pregnancy, you tell them, look, before you get pregnant, let me know, because I might just empirically increase your dose to the women of the thyroxine by 20 to 50%, 25 to 50%. Next hormone that there's interactions, growth hormone and thyroid. So there's a risk with hypothyroidism with growth hormone therapy if you're not already on thyroxine therapy. Just remember that there's these interactions, okay? So they often need higher doses of thyroxine, because what growth hormone does, again, it lowers thyroxine levels, okay? So a lot of interactions here. Estrogen, women on estrogen that are taking it orally need higher doses of growth hormone. If it's topical, they don't, because they avoid the which effect in the liver? The first pass effect, right? They avoid the first pass effect. Okay, so those are just some nuances. Those are more endocrine, high level, but it's important to know some of them. I'll tell you the ones you need to remember as internal medicine doctors, okay? It's the diabetes insipidus one and the adrenal therapy before thyroid therapy. Those are life-saving. If you forget the growth hormone one, which you're not going to use, don't worry about it. But don't forget the diabetes insipidus and the adrenal one and the thyroid one. So how do you manage these patients perioperatively? We talked about chronic therapy, right? But someone's gone for pituitary surgery, what do you do? So generally speaking, for pituitary surgery, if they're hypopit and you know that, give them stress dose steroids. Do you guys have availability of hydrocortisone constantly, generally speaking? Generally, because I've used it here. I've used it for other reasons in Uganda when I did some clinical stuff here. But IV hydrocortisone, 50 to 100 milligram every 8 hours and taper very quickly. Usual thyroxine dose. And for DDVP, generally speaking, post-pituitary surgery in the hospital, we use sub-Q or subcutaneous or IV, because often they go through the nose, right? So the nose might have packing. There might not be allowability or packing issues, so you can't use the nasal route initially. But if they're discontinued and they really do need it because they have real DI, then you're going to use another form. Now, remember the other teaching point is that most people, the DI is temporary. About 4 to 5%, the diabetes insipidus is permanent. 95% of the time, if they have no preoperative DI, but they have postoperative DI, it's transient 95% of the time. So what I tell them is, look, I might give them a prescription. If your water output settles down, don't take it. If you start having a lot of urine and you have the symptoms, get this blood work done, start taking a small dose of DDVP, and call me. Then when I see them back in clinic, I'll take them off again and re-challenge them. But I would say 90%, when was the last time, remember, Medina, that we sent someone home on DDVP? It's very uncommon, right? Because our surgeons are very good and most people don't need it. So we don't send them home on. But there is about 5 to 10% that need chronic DDVP, and that's fine. So most people don't go home on DDVP. Another teaching point is that at 6 weeks, make sure we retest all the axes, growth hormone, adrenal, thyroid, gonadal, because many of them may recover, and the ones who don't, then you might treat them. And the ones I'm really worried about is the adrenal axis. So if I'm not sure when they're in hospital, I might put them on a little bit of hydrocortisone, then I'll take them off 24 hours before or 48 hours before and retest it to see if they really need long-term glucocorticoid therapy. Because I don't like to commit. I'm actually more of a de-prescriber than a prescriber. Funny you think, right? Because I do general medicine, and the best time to take people off drugs is when they get admitted to the ward. You stop their Haldol, you stop their benzodiazepines, you stop the statin in the 90-year-old man who's got dementia, you stop their bisphosphonate because they can't walk. They're never going to fall, right? So it doesn't make clinical nonsense, right? Clinical nonsense bothers me, right? So we stop a lot of drug at best time, right? And just deprescribing is awesome. Okay, what about non-pituitary surgery? It depends on the surgery. It depends on the surgery, it depends on the duration, when are they going to be eating, and this is important for internal medicine exams, okay? This is a classic non-endocrine question. Non-pituitary surgery, thank you. So major surgery, stress dose them. Moderate surgery, half a dose. Minor surgery, cataracts, colonoscopy, cystoscopy, give them double dose for 2 or 3 days and they're fine, okay? But again, what is the literature behind this? It's horrible. It's anesthesia literature from the 1960s, which basically at the end of the day, do what's best for the patient and listen to your colleagues who have done a lot of this. Not very good literature. I want to end off with, I think this is my last slide, we're ahead of time actually, which is good, is management in pregnancy. I can never forget the pregnant woman because a lot of endocrinology, there's a lot of pregnancy. So we must know pregnancy and endocrinology, and pregnancy and cardiology, pregnancy and respirology, pregnancy and ID. There's a lot of drugs and stuff, right, and different issues. But endocrinology, there's a lot of endocrinology and pregnancy. So HC is hydrocortisone. When a woman is pregnant, they may need higher doses, especially in third trimester, T3. Don't use dexamethasone. Again, another reason for not using dexamethasone in pregnancy, because all the other glucocorticoids are inactivated by the placenta. If you give someone dexamethasone, you don't want to reach the fetus. We don't want the fetus to get glucocorticoids because they're going to become Cushingoid, right? Imagine that'd be a disaster. So if you give them dexamethasone, it's going to freely cross the placenta and the fetus is going to have serious issues. So use Pred, hydrocortisone, cortisone acetate, or prednisolone. And in active labor, they should probably get stress dosing. Anywhere from 25 to 50 milligram Q8H with a rapid taper. And that could be either a cesarean section or active labor, which is spontaneous vaginal delivery. Thyroxine in pregnancy, at the onset, I bump up their dose. What I do, the recommendations are, I tell them to take 2 extra pills on the Sunday or one of the days of the week. That's roughly 25 to 50% higher dose, and check their TSH in about 6 weeks' time. Then I check it usually every week, every 4 weeks in the first trimester, then every trimester thereafter, roughly. Now, DDVP. Does anyone know if pregnant women need more DDVP or less DDVP? And again, I love physiology. I was trained in physiology. Why may women need different doses of desmopressin in pregnancy? Anyone? Again, pharmacokinetics and a little bit of pharmacodynamics. They're different, right? Pharmacokinetics is a little bit different than There's a little bit of dynamics and kinetics here. What's the reasoning, guys?
Increase blood volume.
You're very close. Felix, smart resident. So increase what?
Blood volume.
Partly, that's not the main answer, but there's never a wrong answer. Partly. What's the most correct answer? Why do some women need more DDVP in pregnancy? So women produce this enzyme called vasopressinase. What does vasopressinase do? It breaks down desmopressin. It's unpredictable. It's more of a common problem later on in pregnancy, but do I bump up their dose of DDVP in pregnancy? I listen to my patient. If my patient has no change in urine output or dyspsia, then I'll leave them on the same dose. But let's say they tell me, oh doctor, I'm peeing a lot more, but I'm drinking the same, then I'll say, let's top up your dose a little. So you got to listen to your patients, okay? Just don't look at blood tests. It comes with the history, then the physical, then look at the blood test, because blood tests might confuse you. And that's the problem we have in the West. They confuse us. We have a lot to learn from our colleagues here because of the clinical context, which is a lot more important. Blood tests are important, but let's not work backwards. Let's work from the top to the bottom. And growth hormone, you don't need it because the placenta makes growth hormone. Not an issue. So I just that's the end of the presentation.